We're very pleased today to have Dr. Stephen Pearson from the Institute for Clinical and Economic Review to talk to us about assessing value of tests and treatments in the U.S. healthcare system, which is a very timely topic. Dr. Pearson is actually coming home of sorts since he went to medical school at UCSF and was a Stanford undergrad. He also had received a Master of Science degree from the Harvard School of Public Health. And he is an internist, health services researcher, and ethicist who is the founder and president of the Institute for Clinical and Economic Review, which is an independent nonprofit organization that evaluates the evidence on the value of medical tests, treatments, and delivery system innovations, and moves that evidence into action to improve patient care and control costs. So a big piece of ICER is not only doing technology assessment, as other organizations do, but actually trying to get it implemented among different organizations. And ICER recently expanded from its base in New England to the California Technology Assessment Forum, which has been around for a number of years, but is now assessing value as well as medical effectiveness. Dr. Pearson is a lecturer in the Department of Population Medicine at Harvard Medical School. Previously, he has been a special advisor in the coverage and analysis group at CMS, which does Medicare coverage policy, and he was vice chair of the Medicare Evidence Development and Coverage Advisory Committee. He's also been a senior fellow at NICE and has been involved in a variety of policy initiatives around improving evidence and value in the U.S. healthcare system. Dr. Pearson.
Thank you, Wade. And it's a real pleasure to be here. And Wade, again, thank you. Wade's been a very important figure in the development of my links back to the California Technology Assessment Forum, where his influence was so consequential for many years. So it really is a pleasure for me to come back to UCSF. I'm going to talk about value. This is a piece of both methods and policy and politics that I think all of us in some way are embroiled in, but it's obviously been picking up steam, and so it's an interesting time to talk about where things are in the United States, to reflect a little bit about what's going on internationally with efforts to determine value. So I'm going to walk through a variety of kind of both in the weeds and higher level issues around determining value, and hope that we have plenty of chance to discuss some of these aspects during the hour. So first, just briefly about ICER. As Wade mentioned, we're an independent nonprofit research organization. We were actually based at Harvard Medical School for most of its existence, and then just recently became fully independent. The mission is exactly as he said. We do evidence evaluations, not just of tests and treatments, but also of delivery system interventions, where it might be community health workers or hospital readmission programs, that kind of thing. But the key thing that we really try to work on is how to figure out how to get it into action, how not just to do a report, technical report, and then kind of hope that people use it, but to try to figure out how we ask the questions and provide a report and work with people afterwards to actually help them use evidence in ways that they might not have otherwise. Our major programs right now are these two initiatives, one in New England called the New England Comparative Effectiveness Public Advisory Council, or CPAC. Never let an academic loose with acronyms. We have to have it for everything. And the California Technology Assessment Forum, or CTAF. I'm going to talk a little bit about them as we go forward, just because they're providing some of the public kind of opportunity to talk about value in ways that really challenge us to think hard about what are the methods that we're using to bring information about value into the public policy sphere. So first, though, just to prime the pump here, this happened just within the past 2 weeks. There was a decision by the National Institute for Health and Clinic Care Excellence in England, still known by NICE, on a new treatment for breast cancer, and NICE said no. And here was the quote that they said about why. They said, "We apply as much flexibility as we can in approving new treatments, but the reality is that given its price and what it offers to patients, this drug will displace more health benefit, which the National Health Service could achieve in other ways, than it will offer to patients with breast cancer." That's why they said no. The company came back and said, look, this drug tackles the disease in a different way to any other breast cancer medicine and provides women with valuable extra time with their families and loved ones, time that you cannot put a price on. So this is just an early sign of what we all know, which is that value is not an easy concept. It can be talked about in a lot of different ways from a lot of different perspectives. This is a very well-honored and time-tested tradition of how we think about value. This is a relatively new one in terms of its public discussion, but it's the way that systems of care and payers, insurers, can think about value. So let's dive deep and see what we can think about this. So obviously value, we could talk all day about value. We have to frame this a little bit by thinking about who cares about value and why. Everybody does at some level. Patients care about value, clinicians, hospitals and practice organizations, insurers, employers, society at large, if we can think of that as something that really exists. And I'm going to be honest that right now I'm going to try to frame the conversation around the scope of how insurers think about value. We can easily reflect and talk about how that does or does not reflect what patients, clinicians, and others may think about it. I could have put manufacturers up here too. But let's talk about insurers, because that's where a lot of the methods and the public policy have been in hot dispute recently. But isn't it, to some extent, it should be easy, right? Values to some extent as we talk about what happens to patients. We might have some contextual issues around some of that evidence and what we think about as important for patients, and then we talk about the cost, and it's just all kind of easy. And I guess what I'm going to say is no, it's not. And let's talk about how, though, payers think about this in a way that they pull it together to consider value. So let's talk about the clinical outcomes. In the United States, different payers talk about the clinical outcomes piece. So we're going to go back, we're going to think about this spectrum over a series of slides. We're going to talk first again about the clinical outcomes. And payers really do talk about and think about this differently even within the United States. So private health plans are largely oriented towards the terms of their contracts that they have with individual patients and employers that says that they must provide what's medically necessary. So to them, they think, is this clinical care, the first part of their thinking about value, they say, is it medically necessary? Medicare talks about reasonable and necessary, as opposed to, it's just slightly different words. But we do have some tradition in the United States of ratings of clinical outcomes. How many of you have heard of the U.S. Preventive Services Task Force and its ratings? I thought so. Good. And their ratings have actually, over the years, picked up some more policy traction, because at the last cycle of healthcare reform, Congress wrote that their ratings now will mandate coverage if the U.S. Preventive Services Task Force says that the evidence is an A or a B. So this idea of rating clinical effectiveness, at least, is something that we are starting to get comfortable with. There are lots of private evidence review companies out there. Some of the better known are Hayes and ECRI, who basically provide reviews to insurers reviewing the clinical benefits of new technologies. And they've devised rating systems, often letter grades, kind of like the U.S. Preventive Services Task Force, but that's been out there floating around for a long time. There's also, kind of more recently, there's been this comparative effectiveness research collaborative that asked me to get involved with them because they felt that none of these efforts were really capturing what would be most helpful for insurance companies, and particularly pharmacy folks who were making decisions. They wanted a different rating system. So hold on, this is going to now look like something that you're going to spend a whole day to learn about, and I'm not going to torture you with it. But this is just to show you that there are additional rating systems out there that insurers, payers are wrestling with and trying to use. This is one that's online right now. They actually identified the evidence rating matrix that my institute had helped develop, working with payers and others. And it's actually kind of a knockoff almost of the U.S. Preventive Services Task Force approach, in which you look at, on one axis, the level of certainty in the evidence, And the other axis is what's the comparative net health benefit when you look at all risks and all benefits over time. And you put those two together and you kind of place a marker of where you think the net health benefit is. Here it would suggest that it's substantial, and you have kind of what we call a conceptual confidence interval around how certain you are of this net health benefit given your level of certainty. So, not going to try to get into the weeds here, but just again, and this is actually now being used by a lot of pharmacy benefit managers around the country, there are tools out there for payers to try to assess and rate the clinical effectiveness, the comparative clinical effectiveness of different interventions. And so if you ask a payer, so what's value to you? They will always start with, well, we make a judgment about the added clinical benefit or the comparative clinical benefit of what it is. So this is a piece. So back to our schematic, and in a sense, there are ways for payers to do this. Not always is there 100% consensus. You get different people in the room looking at a body of evidence, and there's been a lot of work, but you still do not have very good consistency sometimes in whether people think that that evidence is strong evidence or whether it's weak. And a lot of people are spending a lot of time trying to come up with better ways to get consensus over what's good evidence on clinical benefits. But let's assume that that's one of the easier pieces and that we've conquered that. But let's talk about the contextual issues. Who could imagine a report on the effectiveness of a new drug for cancer? And what you've got are the reports that have been published in the New England Journal or wherever it is. And you're being asked to judge, what to do with that evidence in terms of the value for a payer. What are some of the contextual issues? Can anybody think of any that you would want more information on that might not be there in that journal article? Anybody think of anything?
FDA regulation, whether it's been approved.
Where that's been approved, good. Well, that's definitely part of the context of what you would want to see when you look at things.
Quality of life rather than just measures of quantity of life that the drug offers.
Good. So in a sense, that's how patient-centered, I guess, the outcomes are that they've looked at. That's very good. That's very good. And don't just think of one thing of cancer, but if payers, and I'll use payers and insurers interchangeably, they have to think about, obviously, lots of different tests and treatments for lots of conditions. And so let me just jump to a slide that will show you some of the contextual issues that payers come into play. And this list was generated through, I think, interviews with over 20 payers around the country, in which you ask them a lot of different, I have these probing questions about types of interventions and what kinds of contextual issues come up for them. So let me just run through some of these. It makes a huge difference to them whether there's an existing treatment that's already available for patients and doctors, and that view of how reasonable it is. Because if you talk to some payers, they say, that's the first question I ask. Are we dealing with a condition for which I can't offer anything, or even a doctor, obviously? Is there another treatment that we could choose, or is this really this patient has no other option? Because what would they think of the evidence differently if there is an existing option?
You might probably take a harder look at what's the cost, whereas say if we're in the early days of AIDS, HIV,
Yep.
maybe we say, okay,
That's not a bad
something is
example.
better than nothing.
That's not a bad example. So, right, so if there's an existing treatment, suddenly that bar of how much certainty I need about the evidence goes up. Whereas if there's nothing else to treat a patient with, I might accept lower strength of evidence, earlier evidence. Now, people will say that's good or bad, but it's definitely a contextual consideration that comes into play. How serious the condition is, if we're talking about alternative treatments for toenail fungus, you might really want to see better evidence before you're going to pay for something that's more expensive or new. Whereas if it's a life-threatening condition, again, it kind of feeds into this issue of how would you judge the evidence as being adequate or not. Does it involve a vulnerable population? That's very important to many payers. They will say, for us, we really think a lot about who's involved, and it will affect our thinking about the evidence. Whether there's a different mechanism of action, actually what's funny about this topic is that this comes up a lot because drug makers often get very excited if they can create a new drug that acts in a different way on a clinical outcome, because they think that will offer doctors and patients more options. Payers, what do you think payers usually say about different mechanisms of action?
It's interesting, but show me the
Interesting,
data.
but show me.
Interesting.
Interesting, but show me.
Interesting, but not high on my list. So, right, they say, show me that the different mechanism of action actually improves outcomes. Don't just tell me that it acts through a different biochemical pathway. Show me that that makes a difference for patients. They consider whether new treatments that are available actually will expand the range of patients, either through different providers can use it, or in some way it helps expand treatment options. Around screening, for instance, colorectal cancer screening, if you come up with something that expands the number of patients in our communities who do get screened, that actually is an important feature of looking at the evidence on that intervention. They think about what impact it'll have on the delivery system. Here it can sometimes get down into the weeds, but some drugs or procedures certainly will have certain practical advantages around the ways that manpower, doctors and nurses or doctors and doctors work together. That's part of the context in which they have to look at the evidence. Then there's some others down here. Sorry, the color coding here goes with a different schematic. But basically, these are other things. I'm not going to run through all of them. But, they want to know whether this is a drug that's likely to be overused frequently, or a treatment. And do we think we can draw a line around the patients that should get this and keep it from being used way outside that boundary? Or do we not really have those tools? Because if we do, then it might be okay to accept a little bit lesser quality of evidence, if you will. But if we don't, and there's a high risk of it being used for this, that, and the other, then we probably want to be tougher, require more. A lot of these get into other kind of more political issues that, again, they do think about. They worry that there might be pushback from clinicians and patients who really want to use this. So that's part of their thinking, whether they're competitive market factors and other things. So there's a long laundry list of contextual considerations, and it's hard, you can't obviously quantify this, but it is really important to remember that any attempt to look at how we judge value and how payers do involves a large kind of qualitative or contextual component. So back to our schematic. We've talked about these two. And cost is easy, right? How much does something cost? I mean, it might differ payer to payer. Maybe they can get a better price. But they can figure out what they have to pay to get, let's say it's a new drug. So in a sense, we've got the three pieces of value, and that should be pretty much all we need to do. But the key is the question. So we have these three pieces. We know the evidence on clinical outcomes. We can talk about the contextual issues. Maybe we can do a better job of making sure we have a clear menu of the issues that we should talk about. And we have the cost. But value is the cost proportional to the benefit given the contextual issues? So let's talk about how different systems and different payers have tried to make that judgment. Because ultimately value is a judgment. So let's talk about different international models. The German and the French, actually the French were first to do it this way. The Germans, no country in Europe can ever do something exactly the same as it, except there are some EU models where they have to do the same thing. But just like UCSF and Stanford, you can't do everything exactly the same. It has to be slightly different. So, and especially between the German and the French. But they do something, they go out and they look at their evidence on clinical effectiveness, and they have a rating of added clinical value. They do that first. They don't look at costs. They don't look at even contextual issues, honestly. They have a very rigorous approach, rigorous to the point of it now, like the French, they have, I think, 6 different categories. Minimal added clinical value, substantial added clinical value, maybe a little bit but need more evidence. They have their kind of categories. And what they do that's really interesting is that they take that judgment that's done by one committee and they hand it off to another group that then basically decides what to pay for it. So they're kind of upstream from the price. They don't take a given price. They say, let's see the evidence on how it works, and we'll tell you what we'll pay for it. That's, in a sense, turning value on its head. It's saying, we'll tell you what good value is. And if you don't give us added clinical value, what the Germans do quite explicitly is they say, we will reference price your drug. So if you don't give us evidence that you are better than what we can currently use, we may pay for you, but we're not going to pay more than we pay for what we've already got. And that's called reference pricing. It's very controversial in economic circles because manufacturing companies think that this really discounts the value of innovation. They say you just, and they think, for instance, the Germans have a reputation internationally of being really tough in these judgments, and you have to show a lot of added clinical value before they will give you that ability to price higher than what's already on the market. So just think of that, because actually we have absolutely nothing in the United States that looks anything like that in terms of how because price setting is a dirty word in the United States. But this is how it's done in a large number of countries. Many of them will benchmark, so if you're Poland or if you're Romania, you will basically piggyback off of these determinations, and then you might even negotiate a lower price, and the companies recognize that depending on the country, they may not be able to afford what the Germans do or the French do. So it's kind of a tiered approach, but it's all based off of this general method of judging value. So the English, got somebody else first, the Canadians and the Australians, they have an interesting approach in which they look at the evidence on the added clinical benefit, but they don't have a formal category approach like the Germans and the French do. And they also look at evidence on the cost, because here they're not setting prices. Here they look at cost information and cost effectiveness analyses, which we'll talk more about. But they don't have a formal threshold. We'll talk all about that in a minute. And they have a very nice, transparent approach to a certain extent, but it's a little bit, again, without these kinds of buckets and then pricing, it's a little bit harder to understand sometimes how the Canadians and the Australians come up with decisions about whether to pay for something new. They will usually say that it's just either the evidence isn't strong enough to show that it adds benefit, or they will discuss a little bit about the cost, but they don't have a really formal way to bring those two together in the same way that the English do. The English have one way to judge value in their system. It is cost effectiveness analysis, and with a threshold. Now they do talk a little bit about social values around the threshold. How many of you know about cost effectiveness thresholds, so that I know when I get into it? We'll do a little bit on this. Because this has been one very, very important line of thinking about value that goes back before NICE in England. Actually, cost effectiveness analysis in many ways was given most of its boost in healthcare here in the United States by Milt Weinstein and others. Even though it never got that much policy traction as an academic field, it has a lot of its roots here in the US. So let's talk about the English system in a sense. First, though, I want to talk about this issue of cost effectiveness being equal to value. So cost effectiveness can be either a cost per a key outcome, such as, let's say we have 2 screening tests for cancer. Let's say it's breast cancer. We have mammography and we have a new version of mammography. One way to think of cost effectiveness is if the goal is to identify a new case of breast cancer, and we've got our standard approach, and this new test is more expensive, how much more do we have to spend for every additional cancer that's identified? Now again, there's no real threshold here, but it's something that payers do think a lot about. They like information on how much, it gives them a gut feeling for value. I'll give you a good example. We did a review of a special radiation treatment for prostate cancer, and the new version had lesser risk of the patient developing diarrhea, kind of chronic diarrhea afterwards. And the diarrhea, though, was usually not that severe. It was kind of mild and could be managed in a variety of ways. And the new version of the radiation therapy, we could calculate it cost $300,000 to prevent one case of mild diarrhea. So that's, and the payers and the others around the room said, that doesn't sound like a good value. But most known is this, cost per some universal health measure, and here the kind of reigning world champion is the quality adjusted life year. But I'm going to show you just a little bit about how it works. Imagine this is cost effectiveness in thresholds 101. But to judge the cost effectiveness, think of one axis being the cost and one being the effectiveness. And this yellow dot, let's assume that this is a current treatment that we have. So whatever it costs and however effective it is, that's where it is. And we're going to compare new things to it. So let's say we have a new treatment that's less effective, see on this line, and it costs more. What value is that to anybody? Not too good. So this is where health policy becomes really easy. You find something over here, you stop, you say, okay, we know what to do. What about this one? This treatment is more effective, we're going out this way, and it's less costly. What do we do?
It never happens.
We give, the voice of experience. Right, well, we give the Nobel Prize, or we do something. We probably send that person out of the lab and into an entrepreneurial setting or something. But you're right, it almost never happens. Why would you charge less for something that's better? Anyway. But so let's talk about the real world then. We have two things here that have happened. We have a new treatment that has low extra cost and a lot, relatively, of health gain, right? It's much more effective, and it's a little bit more expensive. Up there, we have something that's a little bit more effective, but a lot more costly. This is where, again, people who use, like NICE in England, who use cost effectiveness to make decisions, they have to decide where, you might say, well, let's say yes to this one, right? It's a lot more effective and just a little bit more expensive. And maybe we'll say no to that one. But the real question is, where's your threshold? This is what a cost effectiveness threshold basically means. It actually can be graphed, and it says that anything below this line we will do. It's good. We'll say that that's high value. We're getting enough gain for the relative cost to say it's high value. Whereas anything above this line is we're spending too much to get the amount of better effectiveness for patients. And that cost effectiveness threshold, again, the real question is at what slope, where is it? Where does it exist? And it's been very controversial, but I'll tell you a quick backstory in health economics history. When the people at NICE were setting up shop, and they knew that this would be their method for comparing all different kinds of treatments, they sat around a table, probably not too much different than in this room, and looked at each other and said, what's our threshold? Nobody knew. They got the world's best health economist on the phone. They say, what should we do? He said, I don't know. But he said, you know what, in America, they decided when they got academic cost effectiveness starting to use $50,000 per quality adjusted life year. And they did that because Congress had decided to cover renal transplants, dialysis for patients with kidney failure. So that's some kind of societal decision that we are willing to pay for dialysis. And dialysis turns out to be about $50,000 per quality back then. So the next question around the table in London was, what's the current exchange rate? Lo and behold, they ended up picking a threshold that was the same, translated into British pounds, benchmarked from the United States years before. Now, believe it or not, here in the United States, coming back to our shores, this actually is being used by some payers, not very many. This is a real-world large pharmacy benefit manager in Pacific Northwest who has a formulary for drugs. You guys are all familiar with the formularies that you have. And their tiers are linked explicitly to QALYs, thresholds per QALYs. So to be basically to be highest value, you have to be less than $10,000 per QALY. The next one is less than $50,000. Then they have a $150,000 threshold. Here they're linking in a little bit with the strength of evidence. So just so you know, I would honestly call these experiments going on in the United States. But what do you think that a lot of people in Washington would say if they saw this? What would they call it?
Ration.
Of course. Even worse, they'd call the people who use this a death panel, and they would say, the quality adjusted life year is fatally flawed because it does not value the life or the quality of life of a patient with disabilities the same as a person who does not have disabilities. And therefore, treating a disabled patient doesn't look as valuable as treating someone who can achieve total health. Lots of reasons, but it is being done, and there's some reason to think that it may grow. So there's another thing about cost effectiveness and value that we haven't talked about yet. Then try to really put yourself in the shoes of a payer, an insurer, and someone comes to you and says, I've got a new drug for you. The cost effectiveness is less than $50,000 per QALY. I think you should cover it. It's high value for you. What haven't you heard yet that would sway your thinking? Let's assume that the clinical information is all clear. Let's assume that you believe the cost effectiveness threshold. There's another big piece of what an insurer needs to hear about before they decide that, yes, this is high value for me.
What's currently available? What are options?
You're close. Well, yes, and let's assume that there are other options, but you've decided that from a contextual perspective, there's no reason to say no. But there is one potential reason to pause, and it's interesting. If I probably were in Canada or United Kingdom, everybody would have gotten it instantly. I haven't told you what the budget impact is yet. I've told you it's cost effective, but I haven't told you what it actually is going to cost you. So when I talk to insurers about value, and this is very different than what I hear when I talk to manufacturers, they will talk about effectiveness and cost effectiveness. Even though they don't want the United States to use cost effectiveness, they will usually say cost effectiveness is a reasonable way to think about value. But the payers really talk about affordability. And this is a term also internationally. These two terms are kept separate most of the time. Even though they really factor in behind closed doors still in every country, there's a tension between the two, which is not always easy to accept. And in England, they explicitly said, nice, your job is this, cost effectiveness. Don't worry about affordability. That's up to us as a society. If you say something's cost effective, is cost effective, our job is to get the tax resources into the National Health Service to pay for it. We make it affordable. You tell us what's cost effective. We don't have that system, and so our payers end up thinking, honestly, more about affordability than about cost effectiveness. Yes?
So I, like you, learned about all this from Milt Weinstein, and so the argument that he always put forward is that even when you've got a fixed budget, you want to spend every last dollar on the most cost effective and then move up to the next most.
Right.
So that's the most efficient use of your resources. So how do you reconcile it with this?
The problem from a practical perspective is, yes, but if we had every single thing we did in our healthcare system lined up in what's called a league table so that we could decide what's most cost effective, we'd start at the most cost effective and go up until we hit our budget cap, and we'd stop. That's actually what they tried to do in Oregon about 20, 30 years ago. Didn't quite work out. But that's hypothetically what you would do. The problem is if you talk to people who actually manage healthcare systems, they have no idea what's the next thing on the list. That if I accept this into my basket, what do I have to throw out? Or do I really have to throw out anything? Can't I just kind of make the waiting lists a little bit longer, pinch a little bit here and there? So there are all kinds of practical issues that make it difficult. But on the other hand, it does help. There are some people both in Canada and the UK who've been playing around with trying to provide managers with lists by cost effectiveness so that when they do have to throw something out to make room for something new, they can actually pick something, and it might not even be in the same clinical area, but it might be something that they can get rid of. healthcare doesn't come in all these little discrete packages all the time. If you get rid of a certain service, you might have to get rid of a whole line of people. You know, like the whole reason that we have warfarin clinics is to provide this one drug. If we get rid of that one drug, we have a whole infrastructure around warfarin clinics, and that we have to, it's kind of destabilizing. So around value and affordability though, again, payers think about total net costs. They don't, you know, they will hear that if it drives up my drug budget, you know, maybe it'll drive down the hospital budget or something like that. Although the bigger the payer, the more often those two people don't ever talk to each other. And so imagine you're a drug company and you've made this great new drug. It's more expensive, but it will actually produce savings, if you will, by preventing hospitalizations later on. Sometimes they have a hard time getting people to hear that value argument because the people that have to spend the money on the drugs don't see that money being saved on the hospital side. It's not part of their budget silo. So it is tricky. Plus, the other thing that I think is somewhat challenging ethically is that the payers will own up to the fact that they really are looking, in my experience, no one's looking out more than 3 years. So what are the incentives, what's the message we're sending to manufacturers, to clinical researchers? Show me the money in the short term, right? If you want to have some payback off of more expensive, I want to see it. And it's partly because they don't think they can actually trust anything that's, you know, kind of modeled out more than 3 years. And there are other reasons as well. But this is, I think, challenging, again, for our discussion about what real value is. If insurers are only looking out this long, then drugs to treat, you know, conditions that might pay off 10, 20 years down the road have a hard time. So let me go through something that will bring this into sharp relief, perhaps. Hepatitis C drugs, the most recent meeting of the California Technology Assessment Forum. We have an advisory board. We say, you know, it's made up of payers, of large provider groups, patient advocates and others. We asked them, what's keeping you up at night? What's going to be a good topic? This one was, you know, people trumpeting this one saying, help, help. We have to figure out what to do. So I'm just going to focus on the value side of this meeting, because one of the things that CTAF does that is pretty unique in the United States is we, in a public setting, talk about the evidence on clinical effectiveness and on value. So we do a model, and for hepatitis C drugs, this is just to show you the structure of it. We ended up looking at one of the new drugs, sofosbuvir, and we looked at its clinical and economic outcomes modeled at 1 year, at 5 years, and at 20 years. And we decided to go out 20 years because part of the promise of these drugs is that they will achieve short-term cures that will pay off financially, if you want to look at it that way, certainly will pay off clinically, and financially later when you reduce liver complications that would lead to liver transplant, hepatocellular carcinoma. So we did that work. First, we had to look at the entire population of California that has hepatitis C. This is our estimate based on the prevalence of hepatitis C in the general population. In California, there would be, again, 217,000 Californians have genotype 1. There are three main genotypes. So let's play this out. This is our population. And this is going to look at the budget impact. So we did look at the cost effectiveness. We looked at how much the new drug cost to achieve an additional patient who was cleared of the virus. So that was our metric for cost effectiveness. And we provided the affordability question, the budget impact. So this is providing the new drugs, not just sofosbuvir, but there's another one, to the 270,000 Californians who we estimate know that they have hepatitis. I want you to focus on this end of the information. These are in billions, by the way, the dollars. This blue bar here is an estimate for what we would pay as a society, I guess you could say, from the payer perspective, if we treated all those patients with what had been the best available treatment. Involved interferon, some other drugs, reasons that patients don't like to take them. But if we treated all those patients, it would cost about $13 billion in the state of California. If we adopted the new treatments, in the first year, after doing so, our cost would go up an additional $20 billion in 1 year, just for the state of California. And these other bars show what would happen downstream as far as the cost offsets. At 5 years, we really haven't prevented very many liver transplants. You get some decrease because patients are healthier, they're spending less on an annual basis, and we've prevented a few. If you go out 20 years, you still basically have not basically made back financially what you've spent in the first year, and you're still well over what you would have spent if you used the older treatments.
You're presuming no give on the price.
Correct. Correct. But we also, modeling about value also allows you to ask some challenging questions, the what if questions. What if it were a different price? The one that came up for this topic was, what if we actually prioritize? That's the word that clinicians prefer to use. What if we prioritize and only treat patients who are sickest? That's about a third of the total. People who with advanced liver disease, if they get the new drugs, you see that we're still spending more in the short term. By 20 years, it's a little bit better than break even. Now again, this has been called rationing. You know, you're looking at rationing. We're not, you know, if these drugs cost a dime or $1 each, which is about what they cost to make, they're $1,000 a pill on the market, then everybody would, you know, a lot of patients, there would be people, you know, throwing these on the streets to have everybody take it as quickly as possible. It is a public health issue. We want to drive down the transmission. We want to get people treated relatively quickly. But the modeling around the value, so we asked the CTAF panel, having seen this information, we had them vote on the clinical effectiveness and the value of the new drugs. Oh, I'm sorry, one more piece of information we gave them. Just by the way, this average cost of switching patients to the new regimens is $72,000 per patient. If we looked at how would that affect everybody's health care insurance premium, it would go up almost 15% in 1 year, just for basically the introduction of 2 new drugs for one condition. If we spread that cost over every single person in California, we would all have to spend 15% more next year for our health care insurance. And even if we just treated the patients with the advanced liver disease, it would still go up 4.8%. Now, no one actually thinks that that many patients are going to suddenly present for treatment all at once, but there was a policy value to looking at this piece of the value equation because it made it a little bit more obvious that we really can't talk honestly about treating everybody with these drugs. So prioritizing somehow doesn't sound as nefarious if there are numbers showing that it's not that people wouldn't want to, it's just that, are you kidding me? We really couldn't do that. The marketplace doesn't have that kind of flexibility. So we asked them to vote. First, they voted that the evidence was adequate to demonstrate the superiority, the clinical superiority of the new drugs. There were some nuances around some of the populations, the different genotypes. Then we said, okay, it's better for patients. They voted almost unanimously that it was a low value. And we asked them to think, you're a Medicaid health system. Do you think this represents a high value, a reasonable value, or a low value? And they voted low value. And why? Because when we asked them, they said, well, it's the budget impact. We think it would, it's just, you know, it's either going to displace other health care or lead to a rise in prices that would basically, it makes it a low value. It would limit access. And they, of course, wanted to go back to stage 1 and say, can't we have a different price to work with? You know, when we asked for recommendations to come out of these meetings, we involved policy experts as well as the panel, and high on their list was, can't somebody do something about the price? These are great drugs. We can't afford them. So our approach to value at CTAF was to have them vote in this way. We showed them this graphic. Low value, reasonable or comparable value, or high value. And we had shown them all the evidence on the effectiveness and the cost effectiveness and the budget impact of these drugs. And here's low value over here. Do you see these 1 through 12 categories? We thought conceptually there are 4 ways that something could be judged low value. Could have worse outcomes with a higher or equivalent cost, comparable outcomes and higher cost, The evidence could be promising but still inconclusive of better outcomes and its higher cost. Or it could have better outcomes and too high a cost. You weren't at the meeting, but I bet you can guess where their votes filtered in. It was mainly right here. Which does what? It gets us back to the question of the threshold. You can't talk even about affordability without in some way intuitively coming back to what does this mean? What if it were a little bit, just as good, but how much of a cost would have been a more reasonable high cost? And that's where we still in the United States, we have no mechanism for that. This is a critical issue still for payers in the United States. And what's interesting is that physicians are actually introducing some novel policy changes in this area. How many of you heard of what the American College of Cardiology did around cost effectiveness in the last month or two? Just a few of you. It's quite striking. They said, we now, in every one of our clinical guidelines, we are going to present value ratings for the services that we're talking about. Now, what's interesting to me is that they decided to use just the cost per quality threshold. And they adopted thresholds, not the British ones, but ones that the WHO put out. But imagine one of the leading physician groups in the United States saying, we're going to talk about costs explicitly in our guidelines, and we're going to use cost effectiveness as our value rating. Now, it's interesting because that won't get at the affordability question. So payers will still say, well, that's okay, but honestly, in the kind of the public policy game or arena, payers don't like to be presented with something that's, here, this is high value. I'm the American College of Cardiology. This new stent is high value. Because now you have to worry about affordability, and I haven't taken it into consideration. I've put a difficult burden on you to say no to a high value service. So a group that I'm working with is actually trying to build both into a different kind of framework in which we would have a comparative clinical effectiveness rating, we would have a cost effectiveness threshold approach, we would also have affordability information and maybe even a threshold. We would explicitly talk about the contextual considerations that are part of the decision making, and we'd come up ultimately with a value rating that includes all of that. So we're working with a consortium of manufacturers actually and payers to see if we can do something like this. And it is interesting in the, I'm not going to go through this. This is some straw man numbers for what those thresholds, for instance, might look like. But basically, what could possibly go wrong with such a scheme? Well, it could still be that even with something like that, we have a lot of internal problems inside groups that are looking at the evidence and making some of these judgments. Inside my group, we have to make sure that we're calibrated in the way that we consider evidence. It's very easy for people to get kind of different impressions. There could be a lot of external pushback. Believe me, anytime the cost per quality adjusted life year shows up in a printed document, people start needing more blood pressure medicines in Washington. It's almost really anathema to many stakeholders in a variety of ways. And we're still in an early phase in which so the ACC is coming out. Guess what? ASCO, the American Society of Clinical Oncologists, they're coming out with their own approach. It's probably not going to be the same as ACC. That framework that I'm working on with this collaborative is not going to be the same. So we might have all these different value ratings and things kind of swimming out there, which will create all kinds of challenges around how to use the information. Now we also have choosing wisely, which is also part of this game too. Yes?
So when you say cost effective,
Yes.
you've got to have some way of measuring the cost, not the price of the drug, but the cost of the treatment that you're saving. Do we really have a handle on that?
Well, if you choose the perspective, which most people tend to do in this kind of work, of the payer's perspective, you basically use the prices that they are paying. That is from the payer perspective, which I started out saying this was going to be framed from that perspective. We use Medicaid because their prices are available, they're transparent. So we know what Medicaid pays for services. It's not exactly the same in each state, but close enough. We use that as basically the input into the modeling and we can look then at the cost effectiveness based on those prices. Does that make sense?
It does. It goes back to costing something based upon charges, which inherently is flawed because we don't really measure what it actually costs to deliver the care.
If you're a payer, you actually don't care what it costs to deliver the care. You care what you have to pay for it. That's what's
Payers don't pay charges in most cases.
Right. So this is looking what Medicaid actually pays, not what they're charged or what, I mean, basically, they don't have that same kind of game. They have Medicaid fee schedules, and that's what they pay. So again, there's lots of tension because Medicaid may not pay the full costs of a service that's viewed to be of high value by others. That's an important but kind of separate conversation. So I think the future is one in which the determination of value by payers and others is going to be increasingly contentious. Hepatitis C has stirred up a real hornet's nest because this is really once in a generation. Those of us who are old enough remember when AIDS drugs were first coming onto the market, they were very expensive. The reason their price came down, patients marched in the streets. They demonstrated in front of Congress. Nothing like that is happening around hepatitis C. Lots of political backstories about why not. But the focus has been on having payers pay this, and the payers are trying to figure out, is this where we try to muddle through and kind of squeeze the evidence so that not everybody gets treated and we kind of spread it out and negotiate a little bit off the top and kind of muddle through? Or do we create a coalition of patients and employers and others and say, we have an unsustainable model for pricing drugs in this country, what are we going to do about it? So a lot of that discussion is going on now, and it's ultimately going to come around to this issue of how we judge value and how we use that judgment to reflect back on what's a fair price. And lots of political and other issues are involved in that conversation.
So there's clearly a need to have single metrics that try to encapsulate both benefits and harms. And quality seems to get as close to that as anything I've seen so far. We're at least trying to make some judgments and comparisons across a wide variety of interventions. So if qualities are a stop sign for so many people for a variety of reasons, what is on the horizon or the alternative? I can't fathom that there's nothing beyond the quality. But if we can't use that word anymore or start thinking about it, and don't say doubt it, but what is it? I mean, it's easy to say we don't like that, but if there's no alternative for something so critical, then it's not even an argument anymore.
So some countries have decided that, for instance, Germany's political history, they were able to say kind of explicitly the quality is not going to be an option for us because we feel burdened by history not to ever flirt with this idea of disadvantaging disabled people and, et cetera. There are political reasons that it probably will not get any traction here, although in the marketplace, again, you're seeing it both in the marketplace in formularies and in the marketplace of what physician groups are doing. There is nothing completely different out there. I mean, conceptually, you can leave the quality out and just do cost per clinical outcome. So again, this cost per case of diarrhea averted or cost per patient cured, those kinds of numbers actually don't have the same concern, but they don't allow you to compare across interventions. That's why the quality is so unique. In England, they continue to tinker with it, partly from political pushback. There's going to be a new phase of what NICE is doing in which they will have weighting of the quality depending upon how severe the illness is. If you take somebody who's very sick and they get a little bit better, that's how much you've gained a quality. If you take someone who's almost perfect health and make them perfect health, that's how much they've gained. It looks like the same. Society says we care a lot more about this than about this. So they're trying to figure out how to weight the qualities in a way that will adjust for that. So there are some methodologic issues within the quality world that are still going to keep moving forward, but there's nothing that's saying we have a much better, completely new tool to try to look at it across different types of interventions. I owe one over this side now. Steve.
So it seems to me an important issue on the context front is the strength and the stridency of an advocacy group. And the hepatitis C group are people who were disadvantaged, they've been drug users, they've been in the criminal justice system, et cetera. It can be hard to get them mobilized. Mothers of autistic kids, slam dunk. How do you factor that in, and where's the social justice in that?
If you go back to that long slide, the kind of political advocacy is something that, again, it's a real world contextual issue. I do know that there's some work to try to see where the coalition, if you want to call it a coalition, there's one very strident pharmacy benefit company, Express Scripts, one of the biggest, I think it is the biggest. It's basically said they want to help form a coalition and to work with people who will try to create this kind of, it's easy to get skeptical though, because hepatitis C community is a very mixed and diverse community, so I hate to create any stereotypes. Many of the leading patient advocacy groups have a history that actually came out of the roots of the AIDS activists, and they're fully supported by the companies that make antiviral drugs. They have had very differing takes on whether they should advocate for lower prices or for insurers pay up. And there's just all kinds of different things going on in that community. So we need, and you know, taxpayers, you're right, it's a little bit harder. A lot of hepatitis C patients are in the prison system. 30% of prisoners in the United States have hepatitis C. And if you're the payer community and you want to create a coalition to say these prices, we want to pay for every patient to get treated as soon as they and their doctor think it's appropriate. The price is what's stopping us from doing this. I met with 15 Medicaid directors yesterday. I've been traveling too much. Yesterday. This is killing them. This is just killing their budgets. They don't know what to do. The VA is divided into districts. There are districts that have hiring freezes, that are laying off people for one reason. They have to make room for the hepatitis C or part of it. And they're even acknowledging that even with those budgetary moves, they're not going to make it, so they're going back to Congress for a special amount. So there's this huge kind of, we have a crisis. We have fantastic new drugs, virtually a cure for an important health disease, a health problem. The crisis is we can't afford it. Yes?
So outside of this dramatic Hep C example, I can see this breakdown of sort of cost effectiveness and affordability, sort of to play devil's advocate, leading to a lot of decisions to say, well, this is like not as cost effective, but it's 10 times more affordable, and we're going to make that decision 10 times, and then our overall approvals end up being, on average, less cost effective drugs than being able to look at the big picture and like, this is our whole budget, and we're going to, over the next 10 years or whatever, we're going to make so many new approvals, and we want those to be the most cost effective drugs.
Payers are actually surprisingly reactive. I mean, they basically wait till something comes through the FDA and then kind of, oh geez, now we have to make a coverage decision. So it's, and they really don't have fixed budgets. I mean, Medicaid's a little bit different. In some ways, they do get actuarially kind of planned a year in advance, and so they feel like they have a fixed budget. But a lot of this is just labeling value doesn't mean automatically that you won't cover things that are low value. It might mean that you require more out-of-pocket payment from patients. So it's not that it's a completely clear pathway to what's going to happen with coverage, but it gives them some techniques to think about what they can do, either to push back on the price or to deal with patient, co-payment sharing, that kind of thing.
So I'd like to thank Steve for